This presentation is about a project called Integrating Gender Equity and Addressing Cisnormativity in Undergraduate Medical Education. My name is Jack Parkyn, and today, along with my colleagues Drs. Lowik and Wiedmeyer, we will tell you about our project method, findings, implementation challenges, and next steps. Intersex trans and two-spirit people consistently report overall negative experiences with healthcare providers. Their experiences range from having to educate their providers to delaying, foregoing, and discontinuing care due to discrimination, and even being denied care. This results in having a system of inequitable care for these patients and negatively impacts their health outcomes, much of which could be avoided if healthcare providers received proper training and were able to provide inclusive care. Medical education is a critical site of intervention for improving the health and healthcare experiences of these patients. Currently, medical research studies, clinical guidelines, textbooks, and medical education generally assumes and expects that patients will be white, endosex, and cisgender. Medical education curricular content on the health of intersex, trans, and two-spirit people is often cursory, optional, and elective, and largely focuses on improving attitudes rather than building and practicing clinical skills. Providers may misgender patients or focus solely on their sexes, gender identities, or sexualities while neglecting other health needs. Despite growing recognition of gender as a key determinant of health and health advocacy as a vital physician competency, medical education pertaining to care of intersex, trans, and two-spirit patients remains limited. Intersex, trans, and two-spirit people patients need access to competent providers in all aspects of healthcare. While education alone cannot address the structural inequities that shape healthcare, identifying and addressing gaps in medical education will help improve clinical encounters between intersex, trans, and two-spirit patients and providers. Medical education literature suggests that there is an overall lack of curricula that focuses explicitly on gender diversity. When it is present, it is routinely collapsed with sexual identity into the category of LGBTQ, with the focus being primarily on sexuality and sexual minorities. This learning is then siloed into additional learning or optional modules rather than integrated across the curricula. Although many medical students believe that education on gender and sexuality is important, many don't feel that they are receiving adequate training. Where trans-specific content is included, it typically focuses solely and exclusively on gender-affirming hormones and surgical interventions to the exclusion of other healthcare needs. This reduction is inadequate and indicative of a lack of understanding of the barriers trans patients face in primary, emergency, palliative, specialist, and other healthcare settings across their life course. Research suggests training in trans-specific content and clinical exposure to trans medicine improves student comfort, confidence, knowledge, and skill to provide care to trans patients.
With the goal of understanding the current state of medical education and to increase the competence and preparedness of future doctors to meet the needs of all patients, we undertook a 16-month curricular audit project. During the first development phase, we conducted an extensive literature review on existing curricular audit projects to learn from their methods. We also launched 2 advisories. Our academic advisory was comprised of 7 UBC faculty and staff working both within and outside of the Faculty of Medicine. This advisory met monthly and assisted with determining the scope and scale and methods of our project. Our community advisory committee was comprised of 15 paid community members who identified as trans or non-binary, and this community advisory met twice to review and provide feedback on our draft tools and methods. In the absence of intersex and two-spirit advisory members, we ensured that we consulted with intersex and two-spirit experts as part of our expert consultation process. We ultimately interviewed 10 experts who had experience delivering and developing curriculum, who had conducted curricular audits, who had relevant clinical experience, who had academic expertise in the areas of endosex and cisnormativity, and who had lived and living experience to share. Finally, we conducted 2 focus groups with medical students. Together, these 5 elements of this phase allowed us to develop our audit method, to determine a strategy and develop associated tools for assessing and evaluating medical education curriculum with an eye towards 2 interconnected problems. First, the erasure of intersex, trans, and two-spirit people from the curriculum, and second, the pervasive misuse of gender and sex concepts, which has profound implications not only for how physicians treat all patients, but which represents a fundamental error in how medicine is taught. During the second audit phase, we piloted our approach using the UBC undergraduate medical curriculum. Based on what we learned during the development phase, we launched 2 surveys, one with current or recently graduated medical students focused on understanding and assessing what they were learning, and one with people involved in designing and delivering that curriculum, focused on what they were designing and teaching. We also built a detailed audit question list, which we used to evaluate the quantity and quality of specific curricular content itemized on this slide. Finally, we analyzed our results and wrote a report of our findings, which Dr. Wiedmeyer will now go over.
We found the curriculum specific to intersex people narrowly focused with inconsistent messaging. Content about trans people was primarily in language and communication skills teaching, and limited to units on sexual and reproductive health, though briefly noted in cancer screening. Two-spirit people were absent entirely except for a single definition. Student and faculty surveys revealed that students felt unprepared for and faculty felt unsupported in teaching this content area. Taken together, we found a profound erasure of intersex, trans, and two-spirit people. We also found that the concepts of gender and sex were frequently misused or incorrectly conflated. Beyond correcting the erasure of these populations, medical education ought to mobilize the concepts of gender and sex accurately and precisely. Gender and sex are distinct yet interconnected variables, the misuse of which has profound negative impacts on all patients. As institutions increasingly state values of inclusion and diversity, their teaching needs to realize these values. A curricular audit can point out areas for change, but is insufficient without actual curricular reform. Faculties need champions with the ability and mandate to make needed changes. This change work needs to be done with the same rigor and accuracy expected in other content areas. We recommend that institutions undertaking audit projects engage people at all levels who can understand the complex dominant ideologies and frameworks being explored. Professional and faculty development are key to the change work, so those who deliver the updated curriculum are prepared to do so. Medical education should not merely provide medical students with exposure to intersex, trans, and two-spirit patients in theory, but must prepare them with the practical skills they need to care for them. Medical education is a critical site of intervention. Our hope is for other institutions to undertake similar audits, inspired and informed by our process, and ultimately improve the health and healthcare experiences of patients who are marginalized and minoritized, including intersex, trans, and two-spirit people. This project was funded by the UBC Faculty of Medicine Strategic Investment Fund and the Center for Gender and Sexual Health Equity. We want to thank everyone who is involved in this project, and please look forward to our forthcoming publication describing our methods in more detail. Our email addresses are also on the slide, and AJ will be available during the conference digital poster Q&A to answer any questions you might have. Thank you.